Thank you. This is my great honor to have this opportunity to join this forum. Thanks so much for the invitation of Professor Long and David Foss to let me say something about the fourth other science, a new tool to explore CNS neuronal function with special focus on Parkinson disease. However, I'm a little bit nervous because I'm just a new beginner and learner and walked into this field only 1 year. I got my approval of my research project 1 year ago and did the first cases 3 months ago. Therefore, today I can only simply and briefly mention about the rationale of my research project and share with the very preliminary data of 3 cases with 1 case illustration. This is the title of my project. The project of this goal is we try to confirm if the new weak intensity of TUS, which showed an effect in rat, also impact on human brain, and to find out the possible transition between the suppression and facilitation protocol. We try to examine what neurophysiological parameters could demonstrate the potential mechanisms underlying the task, and to find out what gate variable could be modified by task. The first, this is my protocol. We will recruit 10 patients with Parkinson disease with freedom gate and 10 patients without freedom gate. After detailed clinical questionnaire evaluation, each patient will receive twice Neuromodulation TUS and receive the comprehensive neurophysiological studies. The first is we want to confirm the weak intensity have the same effect that we noted in the animal rat. In last year, in 2023, my team published this paper. We used the weak TUS intensity, only 8% duty cycle, and transcranial SPTA 3.3 to 8.5. This weak intensity can significantly decrease the amplitude of the motor potential over the primary motor area. We also noted interesting that if very weak intensity can transiently facilitate the MEP amplitude. This finding is parallel with the result published by Michael Braskin in 2016. He reviewed the literature and suggested that using the lower duty cycle and lower intensity, the TUS will provide a suppression effect and go beyond the traditional higher duty cycle and high intensity will provide a facilitation effect. Therefore, try to suppress the brain, use the 18 milliwatt and facilitating the brain for 72 milliwatt. This intensity level is compatible with level 1 and level 2 of Navy Force. This is all 1. The second question is, which brain area should be enhanced or should be suppressed? There are many brain areas have been suggested to be beneficial after non-invasive brain stimulation for the motor control, for the cognitive performance, and for the mood behavior. In terms of motor control, there are 3 hot topics. The first, primary motor cortex, supplemental motor cortex, and premotor cortex. Among them, the supplemental motor cortex show increased activity by the neural image study and the metabolic analysis. Therefore, Professor Ugawa published this interesting and large-scale paper showing that suppress the supplemental motor area by inhibitory 1 Hz RTMS will significantly improve the motor scale of Parkinson disease and the questionnaire of gait. Moreover, the Professor Jacob identified that the suppress the supplemental motor area will significantly increase the amplitude of APA, anticipatory posture adjustment. The amplitude of APA is the key determinant of the gait initiation. Based on this perspective, we make decision that we use the 18 milliwatt as a low intensity to suppress the supplemental motor area and use the 72 milliwatt to facilitate the primary motor cortex. After each section, they will receive the comprehensive neurophysiology study. We decide to test we decide to test the synaptic plasticity as a neurophysiological marker to check if task is effective or not. What is the neuroplasticity? Neuroplasticity, synaptic plasticity is the ability and capacity to change the neuronal synaptic function. For example, if the synaptic function is status A, we can use many methods to manipulate the status into status B by long-term depression, decrease the amplitude, or increase the amplitude by long-term potentiation. That is the synaptic functions examination. The neuromodulation, for example, have the TES, TMS, and TES. Now we turn another fast transcranial ultrasound stimulation TES. Take the RTMS as an example. If the excitability at the baseline here, we can use the repeat RTMS 1 Hz to suppress the amplitude. We also can use the RTMS 5 Hz to enhance the amplitude. That is long-term depression effect and that is long-term potentiation effect. Another method apart from the RTMS is TBS. TBS is we use 3 stimuli at 50 Hz as a burst, and every 200 milliseconds repeat this burst. That is 5 Hz. 5 Hz go into the theta range. Therefore, we turn that is theta burst stimulation. The theta burst stimulation have 2 patterns. The first one is ITBS, intermittent. The second is continuous CTBS. The ITBS is that we provide 10 bursts for 2 seconds and take a rest about 8 seconds. This is the cycle. Then we can repeat 20 cycles for 190 seconds. That is ITBS. And the CTBS, we continue 100 or 200 bursts for 20 or 40 seconds. That is 300 stimuli or 600 stimuli. The TBS, TMS, ITBS will enhance the primary motor cortex for 20 minutes, and the CTBS will suppress the motor cortical excitability for 20 minutes. That's the TBS, TMS. So currently, many researchers borrow this concept to establish their stimulation paradigm or protocol, turn the TBS, TUS in this way. So CTBS or CTBS, TUS or ITBS, TUS. The question is, what is the CTBS pattern, what is the intensity, and what is the duration? This is the basic template of CTBS, TUS, and ITBS, TUS. The current report using this template, the total burst only the 20 milliseconds, and burst duration is 200 milliseconds, and take the rest of 180 milliseconds. That is the ITBS. So you can see, currently, that's the 2 papers published but completely different result. The Rou-Shayn group published 6 months ago with the CTBS for 80 seconds. And another Kim group published two months ago, totally used the same protocol, but they complete a different result. Rou-Shayn showed the enhancement when the Parkinson disease on medication, but Kim's group showed suppression. So the same protocol, but different result. Moreover, the Kim also showed that no matter the superficial stimulation or deeper stimulation, superficial is 5 millimeter stimulation, deeper stimulation is 33 stimulation by the same effect, as well as the ITBS still have the suppression effect. So that is a very different results and diverse results. We have to more focus on and work on that. This is my brief recall. The so weak task intensity can significantly suppress the MEP amplitude or facilitate the MEP amplitude. Either the task intensity is low. also identify the SICI that is show interval intracortical inhibition or intracortical facilitation. Then we can show a trend that the suppression protocol will transiently decrease the SICI. We decrease the SICI, that means the GABA A pathway should be worked on. And then the ICF will enhance, that means the high threshold glutaminergic pathway could be worked on this mechanism. So, but unfortunately, we cannot find any clinical effect, no matter the temporal parameter or the spatial parameter on gait analysis. These three cases did not show the clinical effect, although I can find the changes neurophysiologically by the MEP amplitude. So my comment with that, with task intensity to effectively render neuromodulating effect on human cortex, at least in patients with Parkinson's disease. However, the clinical impact is not permission the high intensity to be necessary. Contrasting the current study 2024 that suggests synaptic plasticity may be underlying the mechanism, because that is high intensity of the Rou-Shayn report and Kim's report, we believe such low intensity should be based on the mechanical sensitivity channel vibration, not directly through the synaptic pathway to induce the D wave or I wave. The third further study will be conducted to focus on the metaplasticity and effective drain change. We try to do something when we perform the task. At the same time, we ask the patient to contract their muscle. That is the metaplasticity. If the mechanism underlying the task through the synaptic pathway, the metaplasticity will work. That means enhance the protocol will suppress MEP. A suppressed protocol will enhance MEP. That is the metaplasticity. However, at the beginning, the F2 is after the concentration. There's nothing changed before, nothing changed compared with the without concentration. Therefore, I believe the weak task intensity should not go through by the synaptic pathway, but rather through the mechanical channel, either the pyroreceptor, AC sensing channel, or the transient protein receptor channel vibration. Thank you for your attention. That is today my sharing. And finally, I ask all of you save your time to join the AOCCN next year. That is the Asian Oceanic section of IFCN. We will organize this international congress next year in Taipei. So save your date and contact again. Thank you.